Good evening to all. Welcome to Ask Your Mentor program, Season 3, organized by Tamil Nadu AOMSI. Today's topics are implantology, salivary glands, and maxillary sinus. Mentors for these sessions are Dr. Satyabama for implantology and Dr. Aditya Murthy for salivary glands and maxillary sinus. The moderator for the session is Dr. Charu Girotra. Dr. Charu Girotra is a professor in the School of Dentistry, V.Y. Patil University, Navi, Mumbai. She had completed her graduation and master's from DAV Dental College and Hospital, Haryana. She has been a speaker in various forums at the national level. She has been a moderator and panelist in various conferences. She has many international and national publications to her credit. We welcome you, Dr. Charu. May I now request Dr. Charu Girotra to introduce the mentors and start the program. Ma'am, you're muted. Dr. Charu, you're muted.
Yes. Thank you so much, Dr. Sasikala, for your kind words. So it's a pleasure for me to introduce the mentors for today. First session is on implantology. So I would like to introduce Dr. Satyabama. She's professor at Ragas Dental College and Hospital, Tamil Nadu. Overall academic experience is almost 15 years, and she has many international and national publications to her credit. She has been guest speaker at various national platforms. Also, she is member of professional bodies like Royal College of Surgeons of England, Indian Association of Maxillofacial Surgeons, and Indian Dental Association. She has many awards to her credit. Also, she has received first prize in oral surgery. This is of interest to the PG residents. And she has also been awarded with Magna Cum Laude by Great Lakes, then Sadbhavna Award by Indian Solidarity Council. Also, she's been facilitated to be a part of UVT on behalf of COVID Resource India 2021. She is very passionate about teaching and working with students and has special interest in maxillofacial implantology, orthognathic surgery, maxillofacial trauma, cleft lip and palate. And the more exciting thing is that she is a vivid runner. She has 6 times participated in half marathon, twice in 32 kilometers. That's really impressive, madam. And she believes in that it's a single life and one must live to the fullest, which I perfectly agree with. We welcome you, ma'am, for the session.
Thank you so much, Dr. Charu. That was very pleasant. And I really am very grateful to the team AOMSI. I welcome the postgraduates on behalf of Team AOMSI Tamil Nadu and Puducherry State Branch, and I wish them all good luck. The topic for today for me is about implants. Implants, as of now, I don't think I should be giving an introductory lecture on what implants are, how they are made, what is the purpose, blah, blah, blah. But then, for the questions that were thrown towards me, yes, were about conventional normal implants. So I'm going to stick myself to the conventional implants and then answer these questions. I do know that there are a few voids in the whole topic. There will be a few topics that would not be covered. Maybe we would do that at a later date. Okay, the first question that was posted to me was about immediate implant and cases preferred for immediate implant loading. Now, all the more, anytime anybody is going to come to your practice or to the maxillofacial clinical center asking for implants, can be anyone starting from a young age group to an adult or an elderly gentleman above 60s or 70s or 80s. Now, if there is a scenario where you would be able to give in an implant and then give a temporary prosthesis to the particular person, then that would be your immediate implant placement, like the one that we see. Now, where and when, what kind of scenarios can you go in for this? For example, this condition here, this root is completely fractured. Okay, this was a sports injury, and then the person came in, with this tooth had also a welt and it was repositioned later. He had another sports injury after our implant placement, can you believe? So this is how the implant was positioned and the temporary prosthesis given to that person. Another case, similar case. Now we could see the crack here on the alveolar crestal margin that goes in but does not propagate itself. We kind of placed this implant to reach the nasal alveolar and the nasal cortex. So we are using a bicortical implant there, kind of engaging both the cortices and trying to give a prosthesis so that we are gaining an apical primary stability, minimum 5 to 6 millimeters, to help us to give a good primary stability. Another case again. So most of these cases that we are doing immediate implant placement the moment we extract the tooth and load the implant as well. Most of the time, these are the anterior teeth, either the uppers, most 95 to 98% are the upper anteriors, though we do the lower anteriors as well. Now, the cases that I would not go in and load them immediately are these kind of sockets. Now, look at this. This is a 3-wall defect. But then this is the lingual cortex, and that is the buccal or the facial cortex. And we have a complete bone loss, and the oral hygiene is not good though. So we placed an immediate implant, but we did not load this implant. There would be people who would be loading this implant, but not me. I would advise this patient to go in for an oral hygiene and then go for root planning procedures, correct this adjacent teeth, correct this OH. Then by that time, it will be 3 to 4 months. Then I can go in for the loading the implant, which will be a delayed loading in that case. So that's, I think this is much clearer in this picture here. So that's the 3-wall defect that we are facing. We did do a complete flap elevation on that patient. The next question is about assessment of stability of implants. How would one go about assessing the implants? Now, primary stability, secondary stability. When we're placing the implants, the first stage, we're placing them, we are torquing them into position, then we're checking the stability of these implants. That is a primary stability. We go in at a delayed stage, a second stage, and then we're checking the stability again, then that becomes the secondary stability. So what are all the methodologies by which one you can check? Okay, the first and foremost is the clinical perception. When the surgeon is manipulating, is handling the bone, the density, either it is D2, D3, or D4. D4 we won't be placing anyway. And anteriors, we are talking about D2 and D3 kind of bone, either in the maxilla or in the mandible. So when we perceive the bone, when we are torquing the implant, then we understand, all right, the bone is not very good, the cortex is good, but then it just dips, the implant will just dip inside, which will mean that the cancellous bone is very soft and the bone is of not good quality. Percussion test is a beautiful test. I love doing this. You resonate. After placing the implant, you just resonate, just focus with your mouth mirror and you get this resonant sound. Okay, so that's the percussion test. That's good. You can do it anytime. It also tells you if your healing collar that you attached has fitted well, or the abutment that you gave in has fitted correctly. Because if there is a dull noise, then the abutment is not fitted in properly. Radiographic analysis will tell us exactly how the positioning is going to be. The reverse torque test, which would not be done normally. Earlier on, this was a test that was advised. Now we don't do this because if you do that, you're kind of reversing the stable implant that's been positioned in place. Insertion torque normally about 40-45 Newton per centimeter is agreed, acceptable. And you can achieve 60-65, but do not go more than that would be the gentle advice, because you would cause micro cracks within the bone, and that would again lead to bone resorptions. Perio test, this device here is used as a perio test. Now that is a probe that goes and hits on the abutment. It goes and hits about 16 times in 4 seconds, and that tells us, and that gives us a score. That score, the lower the score, the the more stable the implant is, and more higher it is very poorly stable. The implant stability quotient, ISQ, is by the RFA, which is the resonance frequency analysis. Now, this is actually a peg. Many companies, there are 2 main companies in India at the moment, but many companies have come up with this across the world. You insert that into the implant, and then you find out the electromagnetic impulses are passed on and the electrical activity is catched up on, and then you get the readings. The readings are around 50 is agreed as a that's the device, that's how it looks like. And around 50 is considered pretty normal. If you think if it is going below 50, around 47, then it is not a very stable implant. So would not advise to load it immediately, and would allow it to integrate, wait for it, again, recheck it. But if it is still dipping down, things below 47, please don't load the implant. That's a failing implant. Now, when we're looking at the dipping, what is this dipping? Initially, when an implant is placed, there is good torquing that has been done, primary stability has been achieved, so the ISQ will be good. But as new bone starts forming with the resorption process, we know that there is bone creeping and reverse bone creeping process that takes place. So when that happens, when your bone is starting to resorb, and then when there is bone formation taking place around 3 to 4 weeks, there is a dip in the ISQ, but then it starts building up again once the new bone is completely formed in. So there's this meta-analysis that was done to find out what was the average ISQ levels, the difference between delayed and immediate implants. And they all found out that anywhere between 65 to 73 was considered a very normal ISQ, implant stability quotient, okay? So the other key factor here is most of the authors vouch by it is that always make a smaller diameter when you're preparing the osteotomy sites for a bigger drill, one size smaller, and just go up to the neck. Don't go to the full depth of it. The next question is about the timing of implant placement. Now, there are different timings. When you load it immediately, that's one. And when you wait for about a couple of weeks, that is called early loading, early implant placement, sorry. And when then you delay it completely, allow the socket to heal completely, and then you place, then that is delayed. So Hammerly classified it as type 1, 2, 3, and 4. 1 will be in fresh sockets, and that's for your exam, guys. This is available. Just take down the classification, name of the person and the year, and you can find that out, okay? So that's about Hammerly. And the advantages are, if it is immediate, okay, single stage, pretty good. Patient has one shot and has the implant done, and he goes out. Either he gets it loaded or he doesn't get it loaded, depending on the scenario. But the disadvantage is because it is done immediately, we still have the soft tissue which have not completely adapted to it, okay? So the recommendation is the facial bone, which is the buccal or the labial bone, okay? The facial bone thickness and the integrity play a huge role here. The authors, they recommend that 2 to 3 millimeter of facial bone should be present, okay? Now, when we talk about this facial bone thickness and the rule of 2 is any kind of anatomical landmark, wherever you want to place your implants, 2 millimeters away from the ID nerve, 2 millimeters below, inferior to the maxillary sinus, 2 millimeters from the buccal cortex. Reason being, the ideal is 1.8 from the facial bone, 1.5 from the lingual bone. So follow a rule of 2, common rule, so that you keep that in your mind. Okay, I have to give 2 millimeters. Okay, if I don't have 2 millimeters, I have a defect there. So that defect, how do I bridge that, the horizontal gap? How do I fill it up? Okay, I can fill it up with different types of materials. And this biotype is about the thickness of the gingiva. If it is a thick gingiva, you do not see the emergence profile is pretty good. It masks everything. But if it's an intermediate type thickness, then okay, you do see certain kind of the PFM or your abutment or your neck of the implant will be visible. But if it is a very thin type, then the response of that biotype to your implant placement and your emergent profile will be jeopardized if you're going to do an immediate implant placement and you don't take care of the gingival recessions criteria, okay? Now, if it is going to be early, then there will be, it minimizes the bone loss, but then there is a low risk of mucosal recession. The aesthetic outcome is much, much better. Now, this again is a thick biotype person. You see that how thick that biotype is, all right? So it completely masks whatever you give to that patient and gives a very good emergence profile and aesthetically pretty good. Now, this is the alveolar crest. The advice is to be 1 millimeter below the alveolar crest, 2 millimeters from the buccal bone, okay? 3 millimeter, minimum of 3 millimeter inter-implant distance. Greater than 3 millimeter, the vertical loss of bone is pretty less. It is not as bad as when there is less than 3 millimeter distance between the two implants. Now, the socket type, now, if it is going to be molars, the anteriors, no problem. So then you must be asking me, what happens in the case of the molars, upper molar, lower molar? How do I place an implant in such a scenario? Now, there is a classification for the type of sockets that is present. It's a beautiful classification. This is where it is. Now, that is the septal bone, okay? And the implant is able to be fitted into the septal bone. There is good amount of intraradicular or septal bone that is present there. Whereas in type 2, yes, there is exposure of this implant into the root sockets, okay? And there's completely no septal bone at all. So the implant has to engage the inner walls of the socket. So that is the different types of socket classifications given by Dennis Kano in 2013. Pretty good. So that will give you an idea. Now, depending upon where your CEJ is, depending upon the amount of septal bone that is present, you can make a plan to say, yes, I can do an immediate placement of implant in this condition if I remove this tooth. No, it is not possible at all. The root is completely resorbed. It's in a very bad condition. So I'm not going to be able to place an implant in this scenario. Okay. So it also gives an idea about the vertical running room for crown contours. Now, what is this vertical running room? This is a 3mm cap subgingivally. That is all it is. Why is this? That gives a good seating of the crown onto the implant. Okay, so in other words, your abatement and your polished collar finish onto the implant. Okay, subgingivally, epicocoronally, if you have at least 3mm of space, then that's a vertical running room, which is very good, allows good self-cleansing, allows the tissues to be adapted well. The biotype gets adapted well. Right. The next question is about platform switching and why is it necessary? Should you do it? Shouldn't you do it? This was an accidental finding, this platform. When Gardner, when they were working on implants, they used the 6mm and 5mm implants, but they did not have the abutment to fit in the size. And they used the smaller abutment size, and they found the results were pretty good. What were the results? The implant and the bone interface is not subjected to all the bacterial invasion that would happen normally. The bacteria that would normally be at the corner here are now pushed on towards the inwards, towards the center. So the interface, the implant bone interface, and the height of the alveolar crest was not jeopardized. It was maintained. So that is why the switching of the platform is being done in cases where we think, okay, I have a good diameter implant, but I want to go for switching and I want to give some thickness for my biotype. And I want to make sure, I allow the biotype to adapt very well. The implant abutment junction is pretty well looked after, and there is self-cleansing, and there is no, macrophages or the bacteria acting on there. The only problem is that causes a deformation of the screw there, because the entire, instead of the abutment sitting proudly on the implant, it is narrowed down and it is pivoted onto the center. So there are reports of deformation of the screw that has happened in such scenarios. This is an example I'm showing of this. The other X-rays, the same patient, what I've given you here is, this is a diabetic patient. Okay, when I placed this implant and I had this review done every year, annually I do a review of these patients. I missed this bone loss that is happening here. And he came back with such a bone loss, and I had to plan for another implant here. So diabetic patients, though they are well controlled, please be aware, please be conscious, put a mark, put a tick on their records to say that I need to follow this person to make sure that his HbA1c is monitored and I am on it. Now, presence of periapical infection, no questions at all, guys. I would definitely say remove, debride, cure it, whatever you do. The classification is such that Susma has classified that into two types, from the implant to the tooth and tooth to the implant. We know this tooth to the implant that happens here. Now, this obviously, I think this was because of the flap elevation and the periosteal supply being lost, and the implant is failing. Nothing to do with the infection right there, but then that is bone loss there and that is failing. So there is a possibility that there can be either way. Whatever it is, make sure that the oral hygiene of the adjacent teeth and the socket in which it is being placed. Well, there is about 2 to 5% minimal less of success of the implant when it is placed in double curated, triple curated sockets. Sometimes even in patients with periapical surgery being done. And these people also have a failure of the implant. There are articles that have represented the failures, about 3% of them. But saying that we can only do so much, but then left is rest is to follow. Okay. Do you recommend grafting of the space? Definitely yes. This is a good classification that I found, which is by Douglas D. Porter. That is the article. He classifies the spaces as buccal, palatal, and that's a semilunar space around the implant. Okay, mesiodistal, and that is a palatal root being engaged with the implant and the buccal sockets being left there. Okay, and this is both buccally and palatal deficiency there. So that is the peri-implant gap classification, that is surrounding the implant, which needs to be filled with bone particles. You can do either whatever we know, autogenous, intraoral, extraoral. I'm not going there. We have allogenous material, xenograftic material, and synthetic materials. Another thing I would like to mention here is the autogenous demineralized dentine matrix. We did quite a few study on this, and we found that when we demineralize dentine, simple, extracting a tooth, patient is going to go for implant placement, extract the tooth, clean the tooth, subject it to demineralization, get that packed into the socket, and these are the granules that have been powdered into the socket, and we found beautiful bone there with all this good marrow spaces, and technically it was considered, the Hounsfield was mentioned as harder than normal bone. I was surprised that I was surprised by the results, but that's a very good option for us, MaxFax, when we are dealing with multiple teeth. Now, implant loading concepts, we know them. They are immediate, early, and delayed loading concepts. Okay. Now, this is a case of an immediate extract, place implants, and load them immediately. Now, if you're going to go for early, then it could be within 4 to 6 weeks or 4 to 8 weeks. And delayed would be later on, once complete healing has taken place, and then you load it. The small cue that I would suggest when you're doing these temporary prostheses is, see, this one here is pretty good. So you need to give that space, the clearance, so that the soft tissue is not injured. This is not a very good prosthesis. This is completely impinging on the soft biotype, and that will cause recession, and that will injure your crestal tissues, and it will get into more bone resorption than normal. Okay, so don't make sure that you do that. Now, direct and indirect sinus lift procedures. We know about this. Directly, you look at through the socket, you expand the depth of the socket into the sinus, place the autogenous or allogenous bone, and then you place the implants. That will be a direct, and that will be your indirect lift. Your direct lift, either you go for cadral loop, or you go for procedures where you open up the sinus and you do that. Now, the complications, whenever we are thinking of placing implants closer to the sinus or dealing with the sinus, always go for an ENT opinion. And make sure there are no polyps, there are no patient is pretty okay, and then get an opinion just to be on the safer side, and then proceed. Now, this is a case of sinus lift that was done. Look at this sinus, which is pretty dipping and very bad, and that is the bone that has been augmented, and the sinus is completely raised up, and this patient went for augmentation with implants. And has very good posterior, upper and lower posterior teeth. Okay, now vertical augmentation techniques. Are there any vertical augmentation techniques? Quite a few of them, because we need to make sure that the crown root ratio is, it's actually crown is to root is 1:2. It should not be the reverse. If it is reverse, then the biomechanics don't work, and it will fail. The implant will fail. The loading will not help the implant. So this is ridge augmentation with GBR. And the problem with that is that gets us exposed, and we have a problem. Now, distraction is a very good methodology wherein you can increase the vertical bone height. And the pretty good at that. Individual tooth, or even 3 to 4 teeth in the segment, a quadrant can be increased in its height. Need to make sure that the vector is maintained properly, and then the transported segment is stable. And it does not tip, it should not tip labially or palatally. That's the cue there. That's a classification, Siebert and Theroden's classification of ridge resorption, where there is very less height, very narrow facial lingually. Both height is reduced and the width is also reduced. So how do you go about doing these kind of cases? There's something called sandwich osteotomy with simultaneous implant placements. Look at this, about 4 to 4.5 millimeters the height from the maxillary sinus level. So in such a scenario, when you have 4 millimeter, you make an osteotomy cut, and you completely fragment this, position that more coronally, and as you're positioning that, you place the implants, and then with the osteotome in its position, and then place the implants and GBR, allogenous particle, periosteal scoring, GBR, and close. So that is a repositioned segment. Okay, we can raise about 6 to 8 millimeters of bone by this kind of sandwich osteotomy. People have done sandwich osteotomy earlier, and then they have done the implant placement later on in the delayed stage. But this is pretty good. It helps the patient quite very well. This is another case. Again, a similar technique, a single implant. Now, bicortical implant is another important thing wherein, when you engage the cortex, it really gives a good primary stability. Either the nasal cortex, okay, or the basal bone cortex, and you're looking at the lower anteriors. Okay, another case involving the cortices. Now, this was a case, a hybrid prosthesis. I just put this in to show you this much. We normally talk about all on 4, okay? Now, this was an all on 5, and patient wanted to retain this. You see that cap, this tooth here. So that is retained and didn't want to take this. So she has an upper denture and a completely, open to impression with, these kind of all on 5 kind of stuff. And the lower hybrid prosthesis that she has had. Now, we really can help do wonders on these patients. Now, again, these small screws are screws which are used to fix bone blocks. Okay, they are not these are the intact screws or mini screws that are used for bone fixation, and these are implants that were placed earlier on. So when we had to do the cutting, you'd use the cutting stent and cut the alveolar ridge, which was knife edge. It was like this. So that was cut, and then we placed these implants and also cut these titanium older implants. And these are dummy pieces. We didn't want to waste bone because that will destroy our bone in placing these implants. So that was, and this is a case wherein customized implants were placed on this patient. Now, what about if a patient comes to you with such a scenario, no bone at all, and patients with mucor, when completely half of the maxilla is resected, or even, so what do you do? How do you go about it? These are called PSIs, which you completely plan up, and they are positioned like we use these zygomatic buttress plates for fixation of fractures. So they have these screws fixed here, pretty stable, and these are the intraoral. So this is fixed on the zygoma buttress on the maxillary base. That's what there, that the piriform aperture here. And these are the abutments, insonates that onto which the prosthesis is fabricated. Okay, so these are patient-specific implants that we make. Now, imagine, look at this person. This is a normal implant. I just wanted to show how you can improve the confidence of a person by just doing your implant procedures. Implants are pretty good. And this is a gingival fibromatosis patient who really had very bad nodular gingiva and wanted implants, didn't want an upper removal prosthesis, so went for all on 4 on such a patient and had that done. And this is how you can really, this is how this patient came in, and this is how she is, and this is how if the process is going on, she's not complete yet. Another technique I would like to mention is about this inferior alveolar nerve lateralization. 2 things you can do. One is the distalization, the other is the transposition and the lateralization. Here we went on with the lateralization technique and removed this inferior alveolar nerve and gave space for positioning of the implants. So these are the implants that are being positioned, and put some PRF on the implant, then put some allogenous material, and then put the cortex that was cut, the cortex that was cut here, and put it back in position and fix it. So the patient had paresthesia for a couple of weeks, But after 3 weeks, it completely, patients absolutely fine. There are no problems at all. Pretty good procedure that is. Okay. Now, the take-home message for all the postgrads out there is follow the basic principles, develop your style, help build confidence in the patients that you're treating, learn from your mentors, and keep sharing your knowledge and let people flourish. Life is a boomerang. Whatever you throw comes back to you. Have a great life and career. I thank the team AOMSI and the secretary, very close to my heart, and everyone else. The president is a very close friend of mine, and everybody in the team. Thank you, one and all.
That was a lovely talk, ma'am. Thank you so much. And implantology is such a huge topic, and you've really broadly covered the planning, implant placement, different grafting techniques, including zygomatic implants and patient-specific implants, which have been extensively used in management of mucormycosis patients for prosthetic rehabilitation. So wonderful lecture on your part, ma'am. I'm sure the students, whatever doubts they'll have, they'll put it on the chat and we'll discuss in the last part of the session. So we move on to our next topic, salivary glands and maxillary sinus. And mentor for this topic is Dr. Aditya Murthy. He's a maxillofacial surgeon with over 18 years experience. And after completing his training in Tertiary Trauma Center in India, he got trained in UK and obtained membership and fellowship from the Royal College of Edinburgh and Ireland. He has extensive experience in trauma, management of oral cancer and salivary gland disease, complex reconstruction of face, and surgery for facial deformities. He has been trained in Geneva's European Sialendoscopy Center and practices Sialendoscopy, which is minimally invasive salivary gland surgery. His interests being temporomandibular surgery, including joint replacement, arthroscopy, treatment of facial injuries, correction of facial disproportions, microvascular facial reconstruction, and Sialendoscopy. He has several national and international publications to his credit and is closely involved in training and academic activity. We welcome you, sir, Dr. Murthy.
Thank you. Right. Okay, so we are going to be short on time for a long topic, but I still have to take time to thank this amazing venture by the Tamil Nadu and Puducherry Association. Hopefully, I should be useful to the postgraduates and the other audience here. We have split these questions into two parts. One naturally is of salivary glands, and the other is of the maxillary sinus and mostly about the oroantral fistula. I'll take you through very quickly. All right. Hang on a second. As usual, my computer is hanging. Can you hear me?
Yes, yes, you are audible. Yes.
All right. Okay. I think we are all right now. Okay. So I have taken the liberty of trimming the questions and modifying them a little bit to make it a little more comprehensive. Now, there was a question about salivary gland pathology. I think the first question was about the different kinds of salivary gland pathology. And mostly, see, there are several ways of classifying salivary gland pathology. And there are two ways of looking at it. One is what would you say in a viva? And the other is how would you treat a patient with this pathology? For me, both of them have to be the same. If you know how to look at a patient with salivary gland pathology, you probably will get your viva answers right. So as far as the salivary glands are concerned, it could be inflammatory, it could be obstructive, it could be infectious, fungal, viral, bacterial, or it could be metabolic. The masses could be benign or malignant, or it could be iatrogenic or traumatic. So there are some decent flowcharts which can help you understand. Some of them are a little busy. What I suggest is that you either take screenshots, or if you can share this, the 2 or 3 of them are very useful for you to both understand and answer questions. So my suggestion is that you look at the next 2 slides carefully. Major salivary gland swellings. Look, it is very simple for you to look at the morphology of the swelling as a part of classification. Is it diffuse or circumscribed? Is it painful or painless? Naturally, painful is almost always inflammatory, and painless is almost always a mass.
Excuse me, sir.
Yeah.
I think the slides are not changing because this is the first slide. Yeah.
What are you seeing now?
Only the first screen, Ask Your Mentor, Seasons 3.
Oh gosh,
So
I have
yeah,
no
we've
idea.
not.
I'm going to stop sharing for a second now. For
Okay.
whatever reason. In the meantime, if okay, no, there's. Can you hear me?
Yeah, you're audible. Yes. Dr. Sasikala, are you there?
Yes, ma'am. Shall I share the screen now, sir? Dr. Charu, shall I share the screen?
Yeah, sir is trying to do that.
Okay, sir.
Yes. I'm going to share screen again now.
Okay, sir.
Any luck?
Yes.
Yes.
Excellent. Thank God.
Go to full screen, sir.
All right. I am a bit of a klutz, only on the computer. I promise you, I'm a better surgeon than that. All right. Okay.
Of course.
Now, so basically, very quickly, circumscribed, diffuse. Such kind of classifications are actually useful rather than going by rote. If it is circumscribed, is it painful or is it not painful? If it's a painless filling, you actually have to be a little worried. It's a mass. What happens if it's a painless filling? Is the facial nerve involved? If the facial nerve is involved, you have to be even more worried. It's malignant. If it is diffuse, what's the reasons for it being diffuse? If it's unilaterally diffuse, is it again a slow-growing inflammatory? Is it a slow-growing lymphomatous? Is it some kind of a chronic infection like tuberculosis or sarcoid? If it's unilateral, what are you looking at? Are you looking at early mumps? Yeah, so these are the kind of points you have to look at when you look at the classification. There are a couple more very quickly. And when you look at the non-neoplastic swellings, there's a very simple, straightforward classification and a lot of fall down options in that. Basically, you have to look at whether it's obstructive, whether it's drug-induced, whether it's developmental or congenital, inflammatory or traumatic, infective or metabolic. So these are the things you have to have in mind. And along the inflammatory ones, I will assure you by far the inflammatory salivary gland pathology and the obstructive subpathology are the most common. You may understand when Mikulicz described his disease, what he spoke about it, when he died, when he was born, how many papers he wrote. It doesn't matter a jot if you don't understand that 90% of your swellings are going to be either inflammatory or obstructive. We do not have such a high rate of adenomas in our country. If you were in the UK, you would see a lot of pleomorphic adenomas, not so much here. And among the inflammatory ones, is it salactasis, which means the pathology is ductal and related to the ducts, or is it granulomatous disease or necrotic salivometaplasia with a parenchyma? You have to understand that the salivary gland disorders, especially the obstructive ones, are mostly ductal, and the rest of them are parenchyma. There are two aspects to this as well. So these are the ones you have to keep in mind when you figure out how to look at salivary gland diseases. Now, the next question is basically, it was a description of parotidoectomies. I have expanded this to see if we can discuss a couple of points regarding management of salivary gland tumors. And when would you treat neck in salivary gland disease? It's a very, very specific question to come from the PGs, but I think it reflects the focus the postgraduates nowadays have on oncology, which is very gratifying. We need far more people in oncology. So how do you match salivary gland tumors? The first question is you go back to the classification. Is it benign or malignant? The management changes entirely. The only useful classification is one which is going to affect your management. Rest of it is a waste of mind space. So if it's a benign tumor, you just remove the tumor if possible. In some cases, it is possible, like in the parotid, where you remove either the tumor or just a little bit of cuff of normal tissue. Whereas in the submandibular gland, it's several times not possible just to remove the tumor or pointless. So you remove the gland itself. However, in malignant tumors, the considerations are far more complex. In malignant tumors, you have to decide whether or not only the tumor with a cuff of normal salivary tissue can be taken out. Is it too dangerous to leave the lymphatics within the gland? Why would you want to remove the whole gland? Is it dangerous to leave the lymph nodes within the gland? Whereas in the submandibular gland, you very rarely find lymph nodes within the gland, and actually it's an aberration. Whereas embryology ensures that there are lymph nodes within the parotid. Several of your parotid abscesses are actually abscess lymph nodes. So in malignant tumors, this translates to the fact that you probably will have to do an entire salidinectomy. What kind of salidinectomy we'll discuss very soon. And when you come to the parotid gland, there are very clear specifics. The standard parotid operation for a long time, for about 8 decades, was a superficial total parotid. Total superficial is removing the full superficial lobe. As against a total parotidectomy, we'll come to that in a minute. When you do a superficial parotidectomy, it by essence is skeletalizing all branches of the facial nerve. You look at the trunk of the facial nerve and gently dissect all the tissues which are lying on the facial nerve, that is the parotid tissue. And the act of skeletalizing would lift the entire superficial parotid lobe off the facial nerve, and this would be a superficial parotidectomy. Eventually, we realized that we are over-operating. And then for the benign lesions, we started doing what is called adequate parotidectomy, which is a very smart way of saying that you're leaving some parotid tissue behind. And several times this would be viable parotid tissue and would work. And when there are very well encapsulated tumors which you can get around, the Europeans started doing something called an extracapsular dissection. You would get onto the capsule of the tumor and very carefully dissect around the capsule and deliver the tumor almost like you have enucleated a benign lipoma or something of that sort. However, in malignancies, you have to understand that the parotid gland embryologically is divided into superficial and deep lobes, but functionally it is actually one single organ. The parotid is one single organ and the cancer doesn't choose its spread. So if you think that the cancer is sitting somewhere where it could involve the deep lobe, you have to remove the entire parotid. Occasionally, you can do what is called a nerve-sparing parotid. Nowadays, unless the nerve is involved, a nerve-sparing parotid, even for a squamous cell carcinoma of the parotid, is the norm rather than the exception. However, if the nerve's already involved, what you do is a radical parotidectomy, because there are some salivary gland tumors which exhibit a very high degree of perineural spread, and getting rid of the nerves in the vicinity of the tumor ensures that there is no recurrence. Okay, so this is about the parotid gland. The submandibular gland. The problem with the submandibular gland is most of these submandibular masses are malignant. You know the textbook story of 80, 20, 20, 80, so on and so forth. 80% of parotid masses are benign and 80% of submandibular masses are malignant. The problem with the submandibular masses is it has to be treated like a neck node. If you think it's malignant, you are not going to be able to pussyfoot around the whole tumor. You are going to excise the malignant tumor along with the appropriate level of neck dissection. In this case, it's going to be 1, 2, 3, 4, unless there are involved nodes, and those nodes would dictate what kind of neck dissection you would have to do. You may have to do a level 5 neck dissection. So time's too short to discuss that. This much is for the neck dissection. However, please understand, in a parotidectomy, you do not need to clear level 1A and 1B in most cases unless level 2 is involved and significantly involved. However, the problem comes here in this case is that if you do only 2, 3, 4 and realize 2 has extracapsular spread, then you have undertreated that case. So there is a fair bit of complexity for neck dissection parotidectomies. So generally a standard neck dissection is adopted. Submandibular glands for benign tumors can be excised either transcervically or intraorally. Intraoral excision for well encapsulated tumors has gained popularity over the last decade or so, especially assisted with an endoscope, and even more so as robotics is becoming standard for transoral surgery. Neck dissection also can be done robotically, while the world is divided currently, as with any new technique. Time will tell us whether this is a useful technique or not. Right. The next question was the important aspects of the salivary What you need to understand is the technique, what incision you would use, what nerves you would protect, and how you would close and manage the complications. In submandibular gland excision, if it's a malignant submandibular gland excision, you would use a bigger incision. You've seen you can see that the inferior border of the mandible is marked out here, as is the swelling. A huge incision, like an apron incision, is marked for your gland excision with neck dissection. And if it's a smaller one, you just need an incision which gives you enough access to get around the gland, identify the marginal mandibular nerve, ensure that you see the lingual nerve, move it out of the way, make sure the hypoglossal nerve remains below the digastric and is protected. And you can see the tendon of the digastric in the photograph here. Unfortunately, and you can see a very fine part of the hypoglossal nerve. So this is the basic tenet in submandibular gland dissection. And as far as parotoidectomy is concerned, there are many incisions you can use. You can use a mini SMAS incision where you raise a SMAS flap, which you cover over the final defect so that you reduce the chances of Ray's syndrome. This is an example where we've used facelift incision, extended facelift incision, and this is a pleomorphic adenoma. The picture on your right shows all the branches. It looks extremely beautiful for you to skeletalize the entire facial nerve. It's very nice on presentations, but trust me, I tell you that the patient takes a long time to recover if he develops neuropraxia. It is okay to leave tags of tissue on the facial nerve. You're not operating for photographs, so you dissect only the amount of facial nerve you need to dissect to get rid of the tumor. You can see that the tumor towards the skin has only its capsule around it. There's no parietal tissue, but there is a big chunk of parietal tissue for the deeper part. And this is how your final closure would look. The next question now. What is Sialendoscopy? Well, Sialendoscopy is endoscopy of the parotid duct, it's a parotid duct only, not the parotid gland. And what are the indications for diagnostic and interventional ones? So basically, a Sialendoscopy can work in obstructive sialadenitis. That's it. Luckily for us, that's a major part of work. If there is an obstruction in the duct for whatever reason, it could be a stone, a stricture, mucus plug, foreign body, polyp, whatever it could be, a Sialendoscopy would be diagnostic, and that's the gold standard diagnosis. And once you diagnose it, at the same time, you could intervene. There are forceps where you can pull out the polyp. You can use baskets or graspers to pull out stones if they're of the right size. And you can dilate the strictures with a balloon, very similar to a balloon angioplasty. And this would do the job. And you do not need to resort to sialadinectomy. It's a travesty in this day and age to resort to sialadinectomy for obstructive salivary gland diseases. And this is a brief bit about interventional and diagnostic Sialendoscopy. Advantage, it's minimally invasive and it's gland preserving. That should do the job. Disadvantages, it's expensive. There's a rather flat, long learning curve, and it's not easily available everywhere. So the success rate is in excess of 95%, but it's technically challenging. And there are significant number of complications like stenosis and perforation, which could eventually lead to gland excision. This is something we've got to be very careful about when you use something new as far as techniques go. This is a very, very useful flowchart regarding Sialendoscopic management of sialolithiasis. This is something I would strongly recommend that you save, share, and use, both for clinical and evaluation purposes in your examinations. Right. The next question is about imaging and diagnostic methods in salivary gland disorders. Ultrasound is one of the most useful, sensitive imaging techniques in salivary gland disorders. It can pick up ductal, parenchymal, and mixed disorders in the right hands. Unfortunately, like surgery, ultrasonology is technique sensitive, and if you do not have a good sonologist and his probe has never traveled anywhere beyond the xiphisternum, if he is an obstetric sonologist, you can get nothing out of an ultrasound. Whereas an MRI is not technique sensitive, your MRI is as good as the machine. and anybody, any good radiologist can read it anywhere in the world for you. And that would be the next best option. If you're looking at a stone, I strongly recommend a computer tomography. And if you're looking at malignancy, especially with an unknown primary or recurrence, a PET scan could be considered. Primary PET scans for head neck malignancies are not yet proven to be of great pickup. Use of contrast agents, especially in highly inflammatory areas and neoplastic areas, are very, very important. The contrast gives you definition of different areas of parenchymal tissue, and you should not hesitate to use contrast, IV contrast for your scans if you think that it's going to add. However, please remember that the kidneys need to be working fine. You cannot have raised levels of creatinine, which indicate any kind of renal disorders. You should ensure that any person with a single kidney doesn't get contrast. And you should also ensure that anybody who's had a previous dye reaction or hypersensitivity to the contrast agent is not given this. Most salivary gland disorders require FNAC, especially in the parotid, especially if you're looking at seeding, which happens with both malignancies and pleomorphic adenomas. Core biopsies are generally avoided as far as salivary gland diagnosis is concerned. And open biopsies in salivary gland disorders are generally limited to tail parotid biopsies for metabolic disorders like Sjogren's, occasionally tuberculosis and sarcoid. And these are not for masses. ANA profile, ACE levels are all useful for either Sjogren's or sarcoidosis. Specific technetium scans used to be used for Sjogren's, but currently the MRIs, MR silograms, and Sialendoscopy have replaced technetium scans to a large degree. Right. At this point, we'll stop the salivary gland discussion and move on to the maxillary sinus. So the first question is something I've modified to cover a fair bit of basic points. What are the most common disorders of the maxillary sinus? Maxillary sinusitis is very common and occasionally quite dangerous. Mostly sinusitis is sinonasal in origin, comes from either the nasal mucosa or the sinus mucosa de novo. However, about 20% of the sinusitis is secondary to dental infection, especially because the roots of the first and second molars especially lie either very close or within the floor of the maxillary sinus. Dental infection can spread directly to the maxillary sinus. Orbital cellulitis is a dreaded complication of sinusitis. The kind of infection notwithstanding, it could be sight-threatening, and this is also very dangerous because the risk of cavernous sinus thrombosis is high. What we see very often in our practices, especially once you finish and you start your practice, mostly binaural surgery practice or outpatient practice, is oroantral communications. These are far more common than you think, and luckily, they don't always come with a disastrous sequel. You can manage them quite easily. A communication is when there is a connection between the sinus and the mouth. Generally, it happens because of an extracted tooth, which is already lying there. It is nobody's fault, and they tend to settle down by themselves. You can manage them conservatively. However, a fistula is what forms when you leave it for a long time and an epithelial tract forms. Why is this important? A communication generally can be closed primarily with just curating that region. You have to be very careful in excising the fistulous tract. Otherwise, that's going to become a festering epithelial source of infection and a cause of failure of your closure. What I have to make sure that everybody understands is, in this day and age, there is no call for not using endoscopy in the management. Most of us are not very comfortable with rigid endoscopy. It is a very good idea to involve an ENT surgeon, because in spite of your management of the oroantral fistula, if there is chronic sinusitis, there is a chance that the sinuses are inflamed, the respiratory epithelium is congested, and the ostium has closed. So your patient may come to you with infection and sinusitis. You do a great job, wash out the sinus, close it, and he keeps coming back to you with symptoms. Sometimes empyema of the sinuses, where your closure breaks down. This is where endoscopic functional surgery, what is called FES, where they open the ostium and allow it to drain, is going to be very useful. See, the cause might be dental, but the effect is going to be multidisciplinary, and the treatment has to be multidisciplinary. Imaging for this most commonly used is a CT scan, very rarely MRI, especially if you think there is a spread of infection. But a CT without contrast shows you the fluid level, the amount of infection, the bone loss in the floor of the sinus, and thickening of the mucosa. But if you want more detail, you can consider a CT with contrast. Now, how do you diagnose and treat a tooth in the maxillary sinus? First off, if there is a tooth in the sinus, if it's iatrogenic, you know how it's happened. You know, somebody's either pushed it up, or there's been a slippage during surgery and it's popped into the sinus or behind the sinus. If it's pathology, of course, it has nothing to do with the doctor. There is probably a dentigerous cyst or a tumor which has pushed the tooth into the sinus, and it's treated accordingly. The investigation, X-rays in this day and age, especially in an urban center, tier 1, tier 2 city, would probably be considered negligent, if you ask me, because the modern CTs have limited radiation. Your CBCTs have even lesser radiation, and they give great detail. So CT or CBCT, MRI, if you think there's a big soft tissue component, and in addition to it, follow up X-rays to see how they are doing post-operatively. How would you approach a tooth in the sinus? Now, if there is a tooth in the sinus and it's been displaced way beyond its own socket, your calval loop will have to be significantly big for you to identify and take the tooth out. However, if it's a small root that's gone into the sinus and you don't think it's justifiable for you to make a big calval loop hole, you could endoscopically get to the tooth, and you could be guided by the endoscope to reach that fragment through the socket. But mostly you will have to make a big calval loop approach, and you can check endoscopically, but calval loop probably remains the mainstay in removing the tooth, mostly because you have to finally make a hole to take out the tooth if it's a big enough fragment or if it's a whole tooth. Post-antral exploration. Occasionally, what you think is a tooth in the sinus is something that's actually slipped behind the anterolateral of the wall of the maxilla and gone posteriorly. This is something that has to be done in the general anesthetic. It has to be localized perfectly with a CT scan, and you have to dig very slowly, very gently, because it can go right behind that, and you may end up having to make an anterior antral window, posterior antral window, and very carefully take the tooth out. This area behind the maxilla is very, very vascular, and better as long as you planned it well, it will go well. But if you dig around too much, it can be quite bloody and a bit of a disaster. What's the surgical management of an orantal fistula? We've discussed the possibility of conservative management and small fistulae. Almost always, these ones will benefit from antibiotics. I'm not very big on using the so-called prophylactic antibiotics, but you will have to assume this is infected, because the flora of the antrum is very different from the flora of the mouth. And once they communicate, you will have to cover with antibiotics. The timing of surgical management matters to a degree, because while the operation is the same, like I said, if it's a fistula, your curettage making a very conducive, nice, clean base as the and converting that fistula into a communication is very important. Otherwise, the surgical principles remain the same. And the techniques which are used, the most common techniques are buccal advancement flaps and the palatal rotation flaps, the so-called von Reherman and the Ash flaps. But post-mucormycosis dealing with huge fistulae, I have become very, very partial to two-layered flap closures using the buccal fat pad if it's available and not atrophic. But most importantly, I use the facial artery myomucosal flap. This is a very useful flap in many other situations, or you can use it as a random pattern buccal myomucosal flap. As backup flaps and rescue flaps, you can use the tongue and the nasolabial flaps. These might be useful in extreme situations. So basically, these are things which you find in most textbooks. I would like to tell you that in the age of implantology, you will lose your sulcus if you use the buccal advancement flap, and you may have to resort to your vestibuloplasty later. And this, my implantology friends tell me that is quite important. And as far as the palatal flaps, you remember that there's going to be a raw area which you need to take care of, maybe one of your stents and bip packs, co-packs, or whatnot. So these are some brief pointers towards some of the questions you asked. And which are the most important factors in post-antral surgery? Basically, it's very, very important that you remember this. This is the maxillary sinus, and that's the uncinate process you see just below the middle turbinate and the inferior turbinates here. You can see that the opening of the maxillary sinus is actually superior to the lowest part of the maxillary sinus, which means that the drainage of the sinus occurs way against gravity. And how do you think it works? Because we have to understand that the maxillary sinus and the sinonasal mucosa, what you read as the ciliated columnar epithelium, they are a living, breathing structure. It is an ecosystem in itself, which is something we have to understand this to understand the rest of the topic we are going to discuss here. So as it waves and moves, it pushes the mucosa into the area of the ostium. The moment it stops moving and stops waving, the ostium starts narrowing. That is where you get sinusitis. Or if there is a primary infection within the sinus, the ciliary movement is affected and the ostium might get congested. Generally, it's reversible. If it's not reversible, you end up with chronic intractable sinusitis. Now, why is that important? We go back here and we look at the antral regime, which was the basic point of this question. So what we do in an antral regime is that you have to provide an antibiotic to ensure that infection doesn't set in. You have to ensure the movement of the nasociliary region. Steam inhalation is generally good, but you got to be careful to what it does to your flap. You have to use decongestant agents. Again, steam itself, it is a decongestant, but about 5 days worth of oxymetazoline or xylometazoline is very important. Ensure that it's used only twice a day and you stop of 5 to 7 days. Otherwise, it causes atrophic rhinitis, a condition called rhinitis medicamentosa. And at the end of it, you ensure that the patient's oral-antral communication is closed and he does not do what's called the Valsalva maneuver. Any increase, like blowing your nose, increases the pressures inside the sinus tremendously, and it can contribute to failure of your repair. So I hope that with this, I have covered naturally, there are going to be topics which are not covered. And if we can take a few questions, I'll be more than happy to answer them. Dr. Charu Virhotra?
Yes. Thank you so much, sir.
It's 9:02.
Very well in time. And the topic and the key questions related to both the topics have been really covered very well. And both the mentors, I really thank both of you for sharing your experience, knowledge, and I'm sure all the PG residents attending will be benefited. Over to Dr. Kalpa.
Yes, ma'am. Thank you very much. With this, we come to an end of the session. On behalf of Tamil Nadu AMSI, we would like to extend our heartfelt gratitude to the mentors and moderators for their time and valuable contribution. Now the participants are requested to stay connected till we fill in the Google feedback form that is posted in the chat box. Filling up this is mandatory for your certificates. Please fill up within 10 minutes. Thank you once again to Aditya Murthy sir, Satyamama ma'am, and Charu ma'am for the wonderful session.
Thank you, Dr. Kalpa.
Thank you, Dr. Kalpa. Thank you, Dr. Charu.
Thank you.
Thank you, Dr. Aditya.
Thank you, sir.
Thank you. It was a pleasure.
Thank you,
Thank you,
postgraduates. Good luck to you all.
Thank you.
Good luck. All the best.
All right.
Thank you, Dr. Jimson.
Thank you.
A quick question. What happens to all these poor questions these people have posted?
So we will be addressing those in the last session of Ask Your Mentor. So we'll get back to you for the answers for that, and we'll be.
I'm coming back again, am I?
No, we are yet to completely plan, but we'll try to address it in the last session, or we'll be emailing it to the participants. So
sure.
The time constraint, we couldn't cover all the questions in the chat box today.
All right. Thank you.
Thank you, sir.
Thank you.
All.
Thanks,
Dr.
everyone.
Jimson.
Thank you,
Have a
Dr.
good night.
Jimson. Good night.
Bye-bye. Bye.
Thank you, everyone. See you in the next session. Good night.